But for some years we've been looking at Ki67 in a different way. That's as a treatment monitoring marker. Now we monitor therapy in medicine in general all the time, right? We monitor blood glucose, we monitor hemoglobin A1C, we monitor blood pressure, we monitor cholesterol. In fact, biomarkers that monitor the effectiveness of therapy are the most useful biomarkers in medicine. So what me and a group of other physicians, I can't say that I'm the only person who invented this, but we started to measure Ki67 not only before therapy, but during endocrine therapy in the neo-adjuvant setting. Because we suspected that if you measure the number of cells actually growing in the tumor on endocrine therapy, that would be a better predictive marker for how the patient did long term than where the proliferation index was at the beginning. So the analogy I would take is if you take a patient with high blood pressure and you give them a diuretic, there's two groups of patients, aren't there? The patients in whom the blood pressure falls, the diuretics are working, they have a lower incidence of stroke. If the blood pressure doesn't fall with the diuretic, they don't have a lower risk of stroke, and in fact you need to give them something else, ACE inhibitor or beta blocker or something. Well, Ki67 we envisaged would be exactly the same way. We'd start the estrogen deprivation therapy or the tamoxifen, and we'd monitor the Ki67 index. And what we've found over the years is tumours that have the capacity to grow, they have positive Ki67 index despite endocrine drugs, do much worse.